Yeah, there is no other side. So it's actually we talk about different patients, and it's all about patient selection. And so I'd like to give you another perspective on this issue. These are my disclosures. So what do we talk about today? We don't talk about the person on the right. We talk about the person on the left and maybe in the middle. So we talk about younger patients, very active, high demands. And so these patients come to you, and this is the group we talk about. So the comparison of total knee versus patellofemoral arthroplasty is not a real comparison, because most of the total knees would probably be on the right. So then it comes to the question, what do you have available? If your only tool is a sledgehammer, then you cut your nuts here like this with the sledgehammer. So you can do that, but it's not necessary. There are better ways to crack a nut. So I think it's important to understand we want to be less invasive as possible. If you believe TKA rules and TKA for everything, okay, you can do that. It's an option. But it's also, if you have other tools available, you can think about different tools. So why? Because total knee arthroplasty is not doing so well as we think. So an entire book I've written about this unhappy total knee replacement, 862 pages, explains why the total knee is not as good as we believe. And when you look up Pavisi and his group and Barak, very famous names here, you see this is what you can expect after a total knee. And when I hear about revision rates of 0% after a total knee, then I think you have two options. You're either lying or you're not operating. This is what my former professor said. If you have no complications, if you have no revisions, you're either not operating or you're lying into your pocket. So 100% survival rates do not exist in real life. So you can make this up for studies, excluding some more patients. And you know, I've seen a lot of scientific papers over the time being editor for the Kester Journal, and we see that there is selective selection of patients for a lot of papers. So it's just not true, and it doesn't reflect reality. So look up the literature, revision rates for younger patients, less than 55 years old. You see this is the Australian registry, and it goes up to 16% after 15 years, and it goes up to 12% after 10 years. These are the revision rates for total knees in patients less than 55 years. And these are the cases you see in the clinic. You see this is a 25 years old female, 60 degrees of flexion, unstable knee. She got a total knee. And she got a total knee. Why? Because there was a patellofemoral tracking problem. She has a patellofemoral problem. She has a patellofemoral instability. She has some OA, but it's not massive. So, and the result is a disaster. 25 years. How do you solve this issue? You can make her a revision total knee, but she will never be happy. So that's a disaster. So to avoid these cases, we need to be more selective. So look at this picture. So everything looks like a dog, but I think there is only one dog on the picture. So you need to understand what you're looking at and then define your treatment. And so now we talk about selective options. Uni, we heard a lot about, but now we talk about patellofemoral joint. So this is the patellofemoral joint, and the patellofemoral joint is very variable. With total knees, you have 8 to 10 options to make this right, but your trochlea is always the same, and then you can decide, do you resurface or not. So you're not able to change your trochlea orientation, and this is a massive problem. Why is this a massive problem? Because we looked at in a study here at the TTTG, and so a lot of you guys would probably say that a TTTG above 15 is kind of not normal, and pathological starts at 20 millimeters. And when you do this with a group of patients undergoing total knee, you see that about 23% are abnormal and 10% have a pathological TTTG. And this is an issue we are just addressing by forcing the patella into the new trochlea. And when you go more into detail, you see here that it depends also on the phenotype you see. If you have a varus phenotype, is less common than in these valgus phenotypes, and that's why the valgus knees are much more difficult to operate on than the varus knees. So what is the true indication for a patellofemoral arthroplasty? It's the sole patellofemoral way. Only treat what is degenerated. There is no overtreatment. Patients are young, but knee is too bad to go for joint preserving surgery. We have tried some cartilage surgery already, so that's the case where you go for patellofemoral arthroplasty. And often you have a patellofemoral maltracking or instability, and it can be seen as a bridging treatment. We hear about revision rates. Clearly, yes, revision rates are higher for the patellofemoral arthroplasty. But why? Because you can revise it easily. So most of these patients can be revised to a normal total afterwards if necessary. But it makes a difference if you implant a patellofemoral knee arthroplasty within the years of 50 years, and then it lasts for 10 years, and then the patient becomes a total, or you implant a total at 50 years or younger, because we know the results are not as good. So the indications are very selective and narrow, and I think it's important to make this clear. It's isolated patellofemoral way, only symptoms at the patellofemoral joint. There is no age restriction, but most of these patients are, I would say, between 35 and 50. Away often in patients with patellofemoral instability, trochlear dysplasia, lateralized TTG, patella alta or infra. And we heard patella alta or infra, this is a contraindication. No, it's not, because the patellofemoral arthroplasty is a complex surgery. It's not only about the arthroplasty. You need to correct all this. You need to correct the patella maltracking. You need to correct the patella infera and also the patella alta if you want to succeed here. So that is clear. You need to have additional surgical skill sets for these patients, and that's TTO, MPFL reconstruction, maybe sometimes an osteotomy, derotational osteotomy. So when we talk about these implants, you can differentiate two different designs. One is the so-called inlay prosthesis, and the other one is the onlay prosthesis. And it's important to make this difference because the indications are different. As you can see on the left, this is a so-called inlay prosthesis. And you can do this in most of the patients, but if you have a severe trochlear dysplasia, it's not recommended to do that because you're not able to restore a normal trochlea here. The onlay is more like your anterior cut on the total knee arthroplasty, and then you put it on, and with this, the trochlea is built in the prosthesis, and that's why it's called onlay prosthesis. The differences here, you can see here, they have different pros and cons and problems, you can see. The outcomes are kind of comparable, but if you have an inlay, you're not creating an overstuffing. The onlay is sometimes creating an overstuffing, and I'll show you later how to avoid it. On the other hand, onlay is better for trochlear dysplasia and instability issues. The surgical technique is comparable. This is, for example, an important thing you need to measure when you do that. You need to measure the anterior offset, and you see the anterior offset on the left picture is smaller than on the right picture. And you need to understand what is the thickness of the implant you put on. If you use an onlay prosthesis that has a 9 millimeter thickness, then you need to cut probably 11 millimeters not to overstuff the anterior compartment. Otherwise, the patient won't be happy. So in these cases, inlay or onlay, there is a trochlea. You see there is some osteoarthritis on the lateral side. You see the patella is reshaped, and you can use an inlay prosthesis. In this case, you would go for an onlay prosthesis because there is no trochlea. So you see there's a massive trochlear dysplasia. There's a lateral tracking of the patella, and that makes it not possible to do that. So I'd like to give you some case examples. If I have some more time, probably time is a bit, but so this is what case example. You see there is a treatment of degeneration of the medial compartment here, and you can do this, that's easily. And then there's a little bit more complex case here. This is a patella alta case, high TTG, and you see the isolated patellofemoral OA. Then you would also do a tibial tubercular osteotomy to treat this, to bring the patella a little bit more down, to make the tracking of the patella perfectly, and also do the patellofemoral arthroplasty. And then in these cases, first you need to do an osteotomy. You need to correct your alignment because there was a massive valgus alignment. So alignment was corrected, but the patella was still not tracking nicely. Can you please come up and so what you end? Pardon? Yeah, I know the time is over, but are you kidding me? This is not very polite. Okay, thank you. So I'd like to show you this case here. Till the end, you see the lateral patella tracking. And so you see the formal osteotomy plate. What you need to do is you need to decide, is your patellofemoral instability more in extension or is it a flexion problem? If it's in extension, then you can go for an MPFL, which we did here, and also the replacement of the PFA. And this really helps the patient in these severe cases to go on with that. That's the result 6 months postoperatively. So preoperative diagnostic steps we skip over due to time. So the results are comparable. We heard from the previous speaker, but it depends on which patient you're looking at, activity level, and revision. It's important to note that you can make a revision to a total knee arthroplasty without any problems, so you can use your primary implants. And so the recommendation is clear. So it's a bridging treatment for these younger patients. And it's not only the PFA which is important, it's osteotomy, it's TTGO osteotomy, and also correction of the alignment. Thank you very much.